Endocrine Disorders, featuring Diabetes, a group project, by Rebecca, Jocelyn, Cece, Celeste, and Nicole. Diabetes mellitus is a group of metabolic diseases characterized by hyperglycemia resulting from defects in insulin secretion, insulin action, or both. In today's presentation, we will focus on the pathogenesis of type 1, type 2, and gestational diabetes. Type 1 diabetes is an autoimmune disorder. Genetic and environmental factors come together, resulting in a gradual process of autoimmune destruction in genetically susceptible individuals. There is a strong association with HLA-DQA and HLL-DQB genes. The most common form is immune-mediated diabetes, and 75% of individuals will develop the symptoms of the disease before the age of 30. Etiology of diabetes type 2. There seems to be a polygenic susceptibility coupled with environmental and other factors that can result in insulin resistance with relative insulin deficiency. Type 2 diabetes is most common in persons over 40 years old, but recent studies have shown an increased incidence in children and is associated with long-standing obesity and hyperlipidemia. Gestational diabetes is defined as any degree of glucose intolerance with onset or first recognition during pregnancy. It complicates approximately 7% of all pregnancies. The exact mechanism is unknown, but insulin resistance and inadequate insulin secretion are contributing factors before and during the pregnancy. Insulin sensitivity declines with advancing gestation and normal pregnancy, but euglycemia is maintained by increase in insulin secretion. Screening should take place between 24 to 28 weeks of pregnancy. Risk factors for type 1 diabetes. If a person has the genetic HLA markers for diabetes, they may be at higher risk for developing type 1 diabetes, but less than 10% of those with the markers actually develop the disease. Other risk factors include triggers by viral infections, race, ethnicity, geography, the northern climates, family history, a diet with cow's milk at a noticeably young age, and having other autoimmune disorders. Risk factors such as older age, sedentary nature of occupation, family history of diabetes, presence of abdominal obesity have all shown to have a significant contribution to the occurrence of diabetes. We will discuss these in detail soon. Risk factors for gestational diabetes. Women who are obese, older than 25, have a family history of diabetes, have a history of previous gestational diabetes, or are of a certain ethnic group, Hispanic, Native American, Asian, or African American, are at increased risk of developing gestational diabetes. Before we break down each type of diabetes, let's explore the organ primarily involved in the process. The pancreas. It is located behind the stomach, between the spleen and the duodenum. It is both an endocrine and an exocrine organ. For the discussion of diabetes, we will focus on the endocrine properties. Within the pancreas are the islets of Langerhans. This is where the magic of proper glucose use takes place. There are 4 types of hormone-secreting cells, including the alpha cells, which secrete glucagon, the beta cells, which secrete insulin and amylin, the delta cells, which secrete gastrin and somatostatin, and then last, the F or PP cells, which secrete pancreatic polypeptides. It is also important for us to talk about insulin. Insulin is a peptide hormone secreted by the beta cells. Insulin secretion is pulsatile, so it increases when the beta cells are stimulated and it decreases when they are not. Some things that stimulate these beta cells include our parasympathetic nervous system right before we eat, increased blood glucose levels, amino acids, and GI hormones. Things that decrease secretion include low blood glucose levels, high levels of insulin, and sympathetic stimulation of the beta cells. Let's talk about insulin and its action on cells. Remember that insulin is released as a response to a stimulus. Once released, it is sent floating through the bloodstream looking for a cell to bind to. Once it has reached that cell, the binding creates a cascading effect that recruits GLUT4 to the plasma membrane. The GLUT4, activated by the insulin, facilitates glucose entry into the cell. So that means without insulin, the glucose is not getting into that cell. This process also includes the transport of amino acids, potassium, magnesium, and phosphate into the cell. Let's talk about type 1 diabetes first. This is the one we most commonly think of as requiring injectable insulin. Type 1 diabetes is an autoimmune T-cell mediated type 4 hypersensitivity against the pancreatic islet beta cells. While an actual cause is not known, it is widely believed that a combination of genetics as well as environmental risk factors have a significant contribution. The pathophysiology of type 1 diabetes. Here are our beta cells. Remember these? Our insulin-secreting friends found in the pancreas. When triggered by a virus or environmental factors, lymphocytes and macrophages infiltrate the beta cells, resulting in inflammation and beta cell death. Autoantigens are then expressed on the pancreatic antigen-presenting cells and circulate through the blood and lymphatics where they initiate an immune response. This immune response activates T helper cells. This creates a cascading effect. Interleukin-2 is released, activating CD8 killer cells, and the release of interferon activates the innate immune system with cells such as macrophages, natural killer cells, and neutrophils. The target of this release, yes, as you guessed it, the beta cells in the pancreas. They launch a full-blown attack of the antigen-presenting beta cells through the release of inflammatory cytokines and toxic perforins, leading to cell apoptosis and death. This immune reaction is amplified by impairments in the ability of the T regulatory cells to effectively suppress autoimmunity. Now, before we jump into the patho of type 2 diabetes, let's talk about metabolic syndrome. Metabolic syndrome is a constellation of disorders including central obesity, dyslipidemia, prehypertension, and an elevated blood glucose level. If you have a patient with these symptoms, they are headed towards the path of developing type 2 diabetes. Type 2 diabetes is a result of insulin resistance. Insulin resistance is defined as suboptimal response of insulin-sensitive tissues, especially the liver, muscle, and adipose tissue, to insulin, and is associated with obesity. Several mechanisms are involved in the abnormalities of insulin signaling pathway and contribute to insulin resistance. These include the abnormality of insulin molecule, high amounts of insulin antagonists, the downregulation of insulin receptors, decreased abnormal activation of post-receptor kinases, and alteration of the glucose transporter or GLUT proteins. As previously mentioned, type 2 diabetes is the response to increased glucose in the bloodstream and increased insulin resistance. This happens through the failure of multiple mechanisms. Adipokines are hormones in white adipose tissue that are associated with increased insulin resistance and decreased insulin production. The more tissue, more adipokines. Free fatty acids formed during lipolysis interfere with intracellular insulin signaling, decrease tissue response to insulin, promote inflammation, and cause beta cell apoptosis. Obesity increases the release of inflammatory cytokines, such as tumor necrosis factor and interleukin-6. These cytokines are released from intra-abdominal adipocytes, hence why central obesity is a huge risk factor, and induce insulin resistance. They play an important role in creation of fatty liver, dyslipidemia, and atherosclerosis. In the GI, there's a decrease in ghrelin and incretin, contributing to resistance and beta cell function. Decreased ability for glucose uptake and use in the skeletal muscle due to insulin receptor damage and metabolism. The liver produces hepatic glucose in response to the beta cell overproduction of insulin, and that is in response to the increased blood glucose levels. The vicious cycle. With the increase in circulating glucose because of the inability of insulin to help the glucose into the cells, there are constant signals being sent to the pancreas to release more insulin. The pancreas thinks more insulin is the answer to hyperglycemic state. Eventually, enough of the beta cells become overworked or damaged and produce less insulin. Another hormone that is produced by those beta cells, amylin, which is responsible for satiety and suppression of glucagon, is also destroyed, thus increasing glucagon release uncontrolled and increasing hunger. In addition, glucagon-secreting alpha cells also become less responsive and release glucagon, even though the body doesn't need it. This excess circulating glucose will eventually exit through the kidneys, causing glycosuria and polyuria. Clinical and diagnostic manifestations. We'll start with type 1 diabetes. Polydipsia. The elevated blood sugar levels cause water to be attracted from the body cells, resulting in intracellular dehydration and hypothalamic stimulation of thirst. Polyuria. Hyperglycemia has an osmotic diuretic effect on the kidneys. This is because the glucose is filtered by the glomeruli, and it exceeds the amount of glucose that can be reabsorbed into the renal tubules, resulting in glycosuria accompanied with large amounts of water lost in the urine. Polyphagia. Increase in hunger results from the depletion of cellular stores of carbohydrates, proteins, and fat, which causes cellular starvation. Weight loss. Weight loss occurs because of the loss of fluids through osmotic diuresis and the loss of body tissue, as fat and proteins are used for energy because of insulin deficiency. Fatigue. Lethargy and fatigue results from the metabolic changes in the poor use of food products, and sleep loss from severe nocturia. Now let's move on to clinical and diagnostic manifestations of type 2 diabetes. Recurrent infections, as well as prolonged wound healing. The increased blood glucose is conductive for growth of bacteria. The impaired blood supply from microvascular damage from high blood glucose hinders healing with a decline in immune protection. Genital pruritus. This is a common symptom with women in type 2 diabetes. High glucose levels and glycosuria favors fungal growth. Visual changes. Diabetic retinopathy can cause visual loss. Additionally, hyperglycemia can cause fluctuations in the water balance in the eye, which can cause visual changes. Paresthesia. These are common manifestations of diabetic neuropathies. Fatigue. As we talked about earlier, lethargy and fatigue results from the metabolic changes in the poor use of food products. Acanthosis nigricans is the brown to black pigmentation in body folds associated with insulin resistance. Now let's talk about some common complications of diabetes. The first one we're going to talk about is hypoglycemia. This is a serum glucose less than 55 to 60 milligrams per deciliter in adults. There is a rapid onset, and symptoms include pallor, sweating, tachycardia, palpitations, hunger, restlessness, anxiety, tremor, fatigue, irritability, dizziness, and confusion, as well as disturbances, and it can progress to a coma and even death. Remember, if they're cold and clammy, give them some candy. Another complication of diabetes is what's called diabetic ketoacidosis. This is seen with blood sugars greater than 250 milligrams per deciliter and a presence of acetone in the plasma. This has a slow onset. Symptoms include malaise, dry mouth, headaches, polyuria, polydipsia, weight loss, nausea, vomiting, pruritus, abdominal pain, and shortness of breath. Small respirations are associated with this disorder. Patients will also have a fruity or even acetone odor to their breath. Another complication with diabetes is what's called hyperglycemic non-ketotic syndrome. This is seen with a blood sugar greater than 600 milligrams per deciliter, but it has a lack of ketosis. The onset is the slowest of all three complications. Symptoms include polyuria, polydipsia, hypovolemia, dehydration, hypotension, tachycardia, hypoperfusion, weight loss, weakness, nausea, vomiting, abdominal pain, hypothermia, stupor, that can progress to coma and seizures. Pharmacological management of diabetes. Insulin. Insulin remains the most potent glucose-lowering agent, particularly for patients with high hemoglobin A1C levels. Insulin is available in rapid-acting, Lispro, short-acting, Humulin regular, intermediate-acting, Humulin isoprene, or premixed formulations. Now let's move on to oral hypoglycemic drugs. These are available to those who are still able to produce insulin. We have the glycosidase inhibitors, and they delay carbohydrate absorption in the gut by inhibiting disaccharides. We have our metformin, and it decreases hepatic glucose production and increases insulin sensitivity and peripheral glucose uptake. The sulfonylureas work by stimulating insulin release from pancreatic cells. Our GLP-1 receptor agonists decrease glucagon secretion, decrease the rate of gastric emptying, decrease appetite, and increase insulin secretion. And our amylin mimetics decrease the glucagon secretion. They also decrease the rate of gastric emptying and decrease appetite. We have already talked about the classic signs and symptoms, such as polyuria, polydipsia, and polyphagia, but there are additional means of diagnosis, and these include urine and blood samples. Ketones and glucose can be found in the urine of the undiagnosed or uncontrolled diabetic. Blood analysis includes measurements of hemoglobin A1C, fasting plasma glucose, oral glucose tolerance test, or a random plasma glucose for an individual exhibiting classic symptoms as mentioned before. Any one of these tests can be used as diagnostic criteria. There are additional supplemental tests that can help clinicians differentiate from type 1 and type 2. These are antibody tests, and they are the best available indicator for diabetes and its different etiologies. Health promotion and teaching. The vast number of individuals with diabetes have type 2, and evidence suggests that prevention with health education and promotion is key to positive health outcomes for these individuals. Increase physical activity. 15 to 30 minutes a day of moderate intense exercise, including resistance as well as aerobic workouts, has shown to decrease the incidence of diabetes type 2. Weight loss is also important and may be indicated for pre-diabetic and diabetic individuals. Eating pattern education is also important, and it includes advising individuals on the benefit of choosing whole foods over highly processed ones. Avoid eating starchy vegetables, added sugars, and refined grains. Education should also include alcohol consumption. 1 or less beverages per day for women and 2 or less for men. Once the diagnosis of diabetes type 2 has been made, interventions shift from prevention to management of glycemic targets, weight goals, and decreasing cardiovascular risks. Because the variety of individuals that are affected by diabetes, therapy should be individualized and modified to reflect the changes in life circumstances, personal food preferences, and disease progression. Thanks for watching our presentation on diabetes. We hope you learned something today. Here are our references.